Okay, cool. So, hi, my name is Brittany Pitts, and today we're going to talk about euthanasia. Every single person in this classroom and on this planet will die at some point. It's inevitable. Furthermore, some of us, if not many of us, will one day be faced with the reality of a terminal diagnosis. If you're terminal and you're going to die no matter what, wouldn't you prefer to be in control of when, how, and where? Wouldn't it be preferable to pass away peacefully in the confines of your own home and comfort, surrounded by your family and the people you love, as opposed to dying a long, drawn-out death in a hospital? This is one of the many reasons why my partner and I believe that physician-assisted suicide should be legalized nationwide, following the structure of the Oregon model of euthanasia under the Death with Dignity Act for terminally ill patients. First of all, we believe that legalizing euthanasia will prevent patients from suffering the torture of unmanageable pain, loss of quality of life and autonomy, for the sake of prolonging a life that the patient no longer wants to live. There are a number of factors that tie into the decision for the patient to request physician-assisted suicide, and many of those reasons cannot be fixed or controlled by medicine or therapy. According to the Oregon Department of Human Services, they state that in the 8th annual report, they characterized 38 Oregonians who died in 2005 following ingestion of medications prescribed under provisions of the Act, and look at whether the numbers and characteristics of these patients differ from those who used physician-assisted suicide in prior years. Providers were asked if, based on discussions with patients, any of 7 end-of-life concerns might have contributed to the patient's request for lethal medication. In nearly all cases, physicians reported multiple concerns contributing to the request. The most frequently reported concerns included a decreasing ability to participate in activities that make life enjoyable, 89%, loss of dignity, 89%, and losing autonomy, 79%. Physicians have consistently reported that concerns about loss of autonomy, loss of dignity, and decreased ability to participate in activities that make life enjoyable as important motivating factors in patient requests for lethal medications across all 8 years. Interviews with family members during 1999 corroborated physician reports. These findings were supported by a study of hospice nurses and social workers caring for physician-assisted suicide patients in Oregon. And in many cases, death is considered a lesser evil to unmanageable pain for terminally ill patients. According to Faye Gersh, the senior advisor at the Final Exit Network, at the Hemlock Society, we get calls daily from desperate people who are looking for someone like Jack Kevorkian to end their lives which have lost all quality. Americans should enjoy a right guaranteed in the European Declaration of Human Rights, the right not to be forced to suffer. It should be considered as much of a crime to make someone live who, with justification, does not wish to continue, as it is to take life without consent. And also, according to Francis M. Cam, the professor of philosophy and public policy at the John F. Kennedy School of Government, he says that they've constructed a 3-step argument for physician-assisted suicide and euthanasia. Assuming patient consent, number 1, we may permissibly cause death as a side effect if it relieves pain, because sometimes death is a lesser evil and pain relief a greater good. Number 2, we may permissibly intend other lesser evils to the patient for the sake of her greater good. And number 3, therefore, when death is a lesser evil, it is sometimes permissible for us to intend death in order to stop pain. Call this the 3-step argument. Secondly, legalizing and putting regulations on euthanasia will create safeguards for the innocent and those who wish to pursue physician-assisted suicide. It's naive to think that non-voluntary euthanasia isn't practiced where euthanasia is not legal. If we were to legalize and regulate this practice, it would become very difficult for the practice of non-voluntary euthanasia against patients to continue. Like I said, even where it's illegal, euthanasia is still being practiced, just without the consent of the patients. According to Laura Donnelly of The Telegraph, in Britain, a 2012 study discovered that as many as 57,000 patients each year die without being told that efforts to keep them alive have been stopped. Instead, they're just shoved onto a death pathway designed to alleviate suffering without ever being told. So basically, doctors in the UK are already practicing euthanasia, only without any of the legal framework to check abuses that would come from legalizing it. So a common fear from the opposition is that minorities and other vulnerable groups could become potential targets for euthanasia. Well, according to Chris DeMar of Time magazine, in places where euthanasia is practiced legally, this is absolutely not the case. In the debate over physician-assisted suicide, opponents have long argued that legalizing it could lead to disproportionately high suicide rates in vulnerable patients. But a new study published in October 2007 issue of the Journal of Medical Ethics suggests that this concern is more fear than fact. An analysis of reports of doctor-assisted deaths in Oregon and the Netherlands, 2 areas where the practice is legal, found that rates of assisted deaths were no higher than average in 9 of 10 patient groups that could be at risk for coercion, such as the elderly or the poor. In fact, the one group that researchers found sought assisted suicide more frequently was younger white men, a generally more privileged few. So these regulations and safeguards are essential to the practice and can only be investigated and upheld if euthanasia is legal. Helen Starks, assistant professor in the Department of Medical History and Ethics at the University of Washington, believes that keeping euthanasia illegal may cause more harm than good. She says that she believes that physician-assisted suicide should be illegal because that allows for more scrutiny and application of these safeguards. The practice is happening regardless of legal status. Keeping it illegal has the potential to cause more harm than good, as it restricts access to knowledgeable social services and healthcare providers who may help patients and families explore other options to achieving a good death, leaving physician-assisted suicide as truly an option of last resort. One concern has been that disadvantaged populations would be disproportionately represented among patients who chose assisted suicide. Experience in Oregon suggests that this has not been the case. In the United States, socially disadvantaged groups have variably included ethnic minorities, the poor, women, and the elderly. Compared with all Oregon residents who died between January 1998 and December 2002, those who died by physician-assisted suicide were more likely to be college graduates, more likely to be white, somewhat younger, more likely to be divorced, and more likely to have cancer or amyotrophic lateral sclerosis. Moreover, although 2.6% of Oregonians are African American, no African American patients have chosen assisted suicide. So, thirdly, it would only make sense for the United States to take a progressive leap into the realm of legalizing euthanasia. The Oregon model has proved without a semblance of doubt that its strict regulations and safeguards, as well as the practice of palliative care, or end-of-life care, is nothing short of fantastic, which is why my partner and I believe that the United States should adopt the Oregon model of euthanasia due to its success. There are a number of regulations and rules in the Death with Dignity Act, which are designed to maintain a patient's autonomy and free will regarding the decision. For example, the patient must be a resident in Oregon, the patient must be aged over 18, the patient must make 2 oral and 1 written requests for euthanasia, there must be at least 15 days between the first and last request, the patient must be terminally ill with a life expectancy of less than 6 months. This prognosis must also be confirmed by a second consultant physician, and both doctors must confirm that the patient is capable of making this decision. Both doctors must confirm that the patient does not have a medical condition that impairs their judgment, and the patient must self-administer the lethal medication. So, like I said earlier, the Oregon model is exceptionally well regulated, which can easily be attested to with a number of studies. According to the Death with Dignity National Center, the strength of the Oregon law lies in its very strict and specific guidelines, which leave nothing to guesswork or interpretation. The 3 main reasons other states hope to replicate Oregon's law are because, number 1, the Oregon law respects and upholds the integrity of the doctor-patient relationship. Number 2, the Oregon law requires that the patient self-administers the prescribed medication to hasten death. And number 3, the Oregon law ensures that the patient, and no one else, is the driving force, the ultimate and conscious decision-maker in the process. The Oregon Death with Dignity law exists only for dying patients whose mental, physical, and emotional suffering has become intolerable and who wish a peaceful and dignified passing. There are many in the disabled community who support the Oregon law, not because they are disabled, but because they are people. To date, persons who have chosen to use this law have been well educated, have had excellent health care, have had good insurance, have had access to hospice, and have been well supported financially, emotionally, and physically. Absolutely no HMO or insurance company participates in this process. Another fear of the opposition is
I gotta cut you off. It's
Okay.
8 minutes and 30 seconds at this point, so
Okay.
they're only supposed to be 7 minutes.